You can start, Dr. Boddu.
Hi, good afternoon, everyone. I'm Srikanth Boddu, one of the neurointerventional attendings at Weill Cornell. Today, I'm going to talk about pulsatile tinnitus and new innovative techniques to solve this issue. I'm going to briefly go about the burden of the problem, how severe or what is the impact of the tinnitus on the society and as a person, and what are the different causes, arterial causes and venous causes, and with a specific emphasis on the venous etiology and the treatment for the pulsatile tinnitus. So depending on where you are from, you may call it as a tinnitus or tinnitus, and basically it means is a ringing noise in your ear. And it can be subjective or objective depending on who is hearing it. If it is only the patient hearing this, it is a subjective ringing. And when both patient and examiner are listening to this, it is an objective one. And depending each patient, when you're especially in the vascular etiology, each patient description is different. Some patients call it as a ringing, whooshing, hissing, whatever it is. Basically, it means a noise constantly present in the ear without in the absence of external stimulus. So that's what it is. And one of the important things to identify in these cases is this going along with the heartbeat or not? And second thing is this changing in severity, getting better or worse with the compression of your neck on the side? So to understand what is the impact of the tinnitus, there is an American Tinnitus Association. They framed a few questions asking went for the public opinion, and it's a conducted survey. And the two main questions in this are, what best describes how tinnitus affects your day-to-day life? If you notice the distribution of this, it is only 4% of the patients says they barely notice it. And another 1/3 of the patients, they say, yes, it is annoying, but it is not significantly affecting their quality of life. But the remaining all, it says either it is ability to focus, either sleeping issues, anxiety, social deprivation, depression, and it's a major impact on these patients. And it's a similar question. It is, do you have any of the following associated health conditions? Yes, if you see, most of these patients have associated hearing loss or hyperacusis, and they are also associated with the sleeping problems, hypertension, and depression, anxiety. And when they put it together in terms of the lost earnings, in terms of the productivity loss and the health expenses they are spending towards this, in patients with a grade 4 or grade 5 tinnitus, they are spending approximately $30,000 every year per person. And as a society, it is costing us $26 billion per year. And what do I mean grade 4 or grade 5 tinnitus? It is based on the tinnitus quantification. This is done with a self-reported questionnaire, which is validated. And this questionnaire takes into consideration of both functional and emotional aspects. The questionnaire has a set of 25 questions. Each question is scored either 0, 2, or 4. And based on the combined score, you go from grade level 1 to level 5. And level 4 and level 5 are the disasters. So they needs to be treated. They are having the severe impact on patient quality of life. Level 3 is depending on what is the patient situation, what are they based on their profession, what is their day-to-day life, they may need treatment as well. And level 1 and level 2, they can be managed medically because it is not impacting their quality of life. So when you evaluate the tinnitus, it is basically starts with the otoscope, and based on how it varies depending on the imaging and with the it varies severity variation in terms of the compression of the neck. It can be categorized broadly into arterial, and venous pathologies. And when it is, by the time we see the patient, we would like to have the imaging ready so we can have an answer for the patient. These includes MRI brain, MRI, that is MR angiography, and MR venography. So we are looking at a structural cause and also the vascular etiology, both arterial and venous for these patients. So if you go into the etiology, starting with the arterial etiology, the vascular stenosis or dissection is one of the common causes. Depending on where the dissection is, if the dissection is happening in the ICA, anterior inferior cerebellar artery, or in the carotid artery, that is internal carotid artery, anywhere from the distal cervical to the horizontal petrous or cavernous ICA, the dissection, both of them can cause the tinnitus. And it is because the ICA gives rise to the labyrinthine artery, which runs along with the 7th and 8th nerves, and also the internal carotid artery gives a branch called a stapedial artery, and these two are the etiology for causing tinnitus. And most of the dissections, as long as they are not causing hemodynamically significant flow limitation, they are treated conservatively with heparin in the acute phase and dual antiplatelets in the subacute phase. And these patients improve over a period of time and with a better recanalization of the vessel lumen. And in patients with a hemodynamic compromise with the recurrent TIAs, then the options vary between the stenting versus endarterectomy, depending on the patient circumstances. And this is another thing is a dural arteriovenous fistula. This is an abnormal connection of the arteries and veins in the brain. And this is a well-known cause for the pulsatile tinnitus, and especially when the branches of the external carotid artery are piercing through the calvarium and before they connect to the venous component. This is a site for the fistulous communication. They can happen from prior trauma or injury or spontaneous development. And this is the MRA finding showing this is normal site, and here this is the asymmetric vascular prominence causing the fistula. And these are again 100% curable with the embolization or just with the Onyx or NBCA, and you make this connection separate and restore the normal flow, and patient wake up from anesthesia, immediately you see there is no more tinnitus. And aberrant vascular loop, this is, you are seeing it when, this is a good example. On the right side, you see the vestibular, this is a 7th and 8th nerve complex. And on the left side, this is a nerve complex, but you see a small branch of ICA looping across it. In this cartoon, you can see the ICA branch, it is looping over this, the 7th and 8th nerve complex. So this is a microvascular decompression performed open surgically. Basically, you are placing a project between the artery and a nerve so that the pulsation is not transmitted to the nerve and that causing the continuous noise in these patients. And now going to the venous etiology. The most common cause for the venous tinnitus is venous sinus stenosis. We all have a prominent venous sinus arching over the convexity of the brain called superior sagittal sinus. And once it reaches to the back of the head, it splits into the right and left transverse sinuses. And if you notice in this patient, there is a normal caliber venous sinus here, but again, as soon as it takes a turn behind your ear here, it is the transverse and sigmoid junction. There is a tight narrowing, it is a severe stenosis. And this causes the turbulence. And because the proximity of this stenosis and turbulence to the mastoid bone, you have the conduction of the turbulence to the mastoid and to the hearing apparatus. And almost half of the patients with the idiopathic intracranial hypertension have this pulsatile tinnitus as a presenting symptom. And here you can see how tight is the narrowing. The superior sagittal sinus here and the sigmoid sinus, but in between the connection part is severely impaired because of the tight stenosis. And this is our normal anatomy. The superior sagittal sinus arching over the top of your head, and once it comes to the back of your head, it splits into the right side and left side. Notice here it's a normal caliber of the venous sinus on both sides, but in cases of venous sinus stenosis, you develop a tight narrowing where it takes a turn behind your ear. So this is where the turn happens, close to your mastoid bone. And that creates a turbulence, and that turbulence is conducted through your mastoid into the hearing apparatus. And the treatment we are offering at Cornell for these patients is a venous sinus stenting, which is a minimally invasive procedure where you access through the femoral vein and stay inside the vein. You go up with a microcatheter and advance, go past distal to the stenosis and drop a stent across the narrowing. So this is a post-treatment. So the stent is deployed in place and it restores the stenosis. You don't need to treat on both sides for these patients because 70% of the patients are born with only one side dominant sinus. So all we need is one dominant transverse sinus to have a normal cerebral venous drainage. So when I say turbulence, so imagine you are watering the garden and this is a normal stream of water. The moment you start to put your finger across the hosepipe, so you are creating a stenosis that creates the jet, more turbulence, and it starts to go far out. So this is the turbulence change from flow pattern from this to this is causing the turbulence, and that is conducted, which is causing the conduction, bone conduction into the hearing apparatus. And that is proven scientifically as well with a flowing 4-dimensional flow imaging. And this is the MRV that shows a normal sinus here, and this is a stenosis at the transverse sigmoid junction. When they did the flow voxel measurements, there is an abnormal flow voxels, that is an increased flow turbulence in this proximal to the stenosis and distal to the stenosis as well. So both above and below, you are seeing this turbulence of the blood flow. And also sometimes you see an abnormal outpouching of the vein called venous diverticulum, and this abnormal turbulence is also noted in patients with the venous diverticuli. And this is what I was telling, it is the superior sagittal sinus and the sinus dominance patterns. Normally we see both sides equal caliber sinuses, but this pattern is only seen in 30% of the patients. 70% of the population, they are born with only one side good sinus. The other side is either extremely small like this or completely absent. So you are heavily reliant only on one side. So if you are treating just one side, a good size sinus with a stenting and reopen it, basically you are opening the freeway for the traffic to go again. You don't, once the freeway is open, naturally you are not choosing to go through the side roads or air routes. So this is another example. This is a pictures of the venogram where you go from the top of the leg and put the microcatheter. So this is the microcatheter, and through this you inject the dye and take some pictures here. And this is pre-treatment. You are seeing the tight narrowing here, and you see given how tight is the stenosis, you are seeing the collateral channel. Because a brain is insufficient flow through the normal pathway. But the moment you stent these patients, your stenosis is no longer seen, and your collateral channels immediately disappears. The time gap between this and this is practically 3 minutes. So when patient is on the table, you immediately see the result that once you open the freeway, brain does not use the side channels. That means no more collateral flow. That means no more turbulence. and you will lose the tinnitus immediately. So these are the patients who wake up from anesthesia, the tinnitus is gone. And the similar situation is seen in patients with the sigmoid sinus diverticulum, and the turbulence is confirmed again on 4D flow dynamic imaging here. And on this one, you are seeing this is the abnormal outpouching, and here is your mastoid bone. And this outpouching with the turbulence is touching the mastoid bone and again conducts that hearing the turbulence as a whooshing noise. And so this is the patient, same patient with the pre-treatment. You are seeing the sinus diverticulum, and most of these patients are associated with adjacent stenosis. You see here, this is the normal caliber sinus, and it should be continuous in the same way. And you are seeing a good caliber superior sagittal sinus here and a good caliber sigmoid sinus. But here you are seeing a focal stenosis. And these patients are treated with the stenting. This is a stent, and the diverticulum is secured with the coil embolization. Again, this is a very instant result. Patient wakes up from anesthesia. It is one of the very satisfying procedures when they wake up and then they don't feel the tinnitus anymore. And it is, we published our experience, and this is one of the immediate impacts of the venous sinus stenting. It is the patients wake up from the anesthesia and the tinnitus is completely resolved. And this is results of our patients. And this is very early experience. 30 patients we published. This is in 2016. And now we are more than hundreds of patients now. And all these patients, the blue line indicates the pre-stent severity of a THI, that is tinnitus handicap inventory. And all these patients are pretty much, it is grade 4 and grade 5 severity. And all of them, they gone to the grade 0. Grade 0 is the one it is they went to. And we have one patient, it is who had the associated, the jugular bulb dehiscence as well. So the patient reported decreased severity, but it is not a complete resolution of the tinnitus. So it is always worth to look for the coexisting pathologies. And as with any procedure, the patient selection is a key for this successful outcome in these patients. So this is the bottom line. One take-home message is, most of the times it is patients come to see me. By the time they see me, they've seen many other physicians, been bumped from physician to physician, and they were told they had to live with it, or you should learn to work around it, or there is no treatment and they had to live with the rest of their life. But in our experience, it is a pulsatile tinnitus is a very much treatable condition with an immediate and permanent resolution of the tinnitus in an appropriately chosen patient population. And what makes all this possible at Weill Cornell is that we have a dedicated pulsatile tinnitus program, which involves a combination of physicians from neurointervention, neurosurgery, and ENT, ophthalmology, and a very well-versed staff, support staff. So this is what takes, and it helps the patient and to improve their pulsatile tinnitus and their quality of life. Any questions? Thank you.
Dr. Boddu, there's a question. I'm gonna give the person the option to come into the call. Oh, no, there's two. James, do you want to ask your question now? You can unmute yourself. Jenny, would you like to ask your question? You can also type your questions in the chat box below. So in the chat box, it says, can you further explain what pulsatile means? Oh, there's a bunch of questions.
Oh, okay. Chat box. How can I see the questions here?
The chat box should be either all the way at the bottom or all the way at the top since you're sharing the screen. And you can click in it. I can read you another question.
Yeah.
Okay. If MRA shows no indication for tinnitus, what are other explanations?
So the MRA is only looking at the arterial system. Most of these patients, especially the younger ones, up to 60s, the most likely cause for them is the venous pathology. That's a venous sinus stenosis or venous diverticulum. So we get the patients MRV with and without contrast.
There's another question.
I got the chat box. Okay.
Okay.
MRA shows. Can you further explain what pulsatile? So this is the one. I'm answering the question. Can you further explain what pulsatile means? So this is what patients say. This is going with their heartbeat. It is rather than having a low-pitched noise, low-pitched continuous. So if it is an arterial one, it is most likely it goes like shh, shh, shh. It is with your arterial heart rate. Whereas the most of the time, the venous one is a low-pitched humming noise. It's a continuous low-pitched humming noise. That's how it is not a definitive, but this is one of the categorization criteria that helps us to separate arterial and venous tinnitus. Can we get a copy of PowerPoint slides? I will leave that to Roseanne to make a decision in terms of the compliance wise. And how would I go about getting a treatment with you? Should I ask my doctor to do a
It will be archived in YouTube.
Sure. So it looks, the presentation will be archived on the YouTube, so you can access this anytime. How would I go about getting a treatment with you? Should I ask my doctor to do an MRA first and bring it to you? What other imaging should be done first? Ideally, it is by the time, in order to avoid the multiple back and forths, if you can get an MRI, MRA, this is the combination to be done in the first instance. And if you can get the MR venography as well, that would be perfect. So we can make a one-time decision and the planning. But I understand sometimes the insurance you'll have a pushback from the insurance companies. So, but in those cases, it is MRI and MRA of the brain is the first choice to investigate, because the arterial pathology like arterial venous fistula, stenosis, they carry a more risk of a stroke or a bleeding in addition to the tinnitus. So we need to evaluate and rule them out in the first place. Once they are negative, then when I see the patient, I will order the MR venogram to assess for the underlying venous pathology. Because venous pathology is never going to cause a stroke or a bleeding. It is mainly the quality of life situation, but how bad it is impacting you that makes that helps us to make a treatment choice. Is pulsatile tinnitus often associated with the hearing loss? Yes, these patients, when they go for audiometry, most of the patients, by the time they see me, they already saw ENT, audiology, and these patients have associated sensory neural hearing loss for the low frequency noises. And that is what's shown. If you see my one of the slides, the hearing loss is one of the common things that is associated. Because it is affecting the low frequency noises, most of the patients don't realize it unless they go for the audiogram and then they see, oh, okay, we are losing some hearing. Is this treatment just for pulsatile? No, it is not. It is for both pulsatile and non-pulsatile. Like I said, it's a pulsatile is more for the arterial pathologies, or like arterial stenosis or dural fistula. These are the arterial pathologies. And the non-pulsatile low-pitched humming noise is mainly for the venous. So the treatment is available for both type of pathologies. Can this procedure help constant tinnitus too, both pulsatile and regular tinnitus if I have both? Yes, it does. But it is, remember, we are not just how patient describes the tinnitus. There is a huge variation from person to person. And sometimes we say, hey, how is your ringing? Patient says, it is no, I don't have any ringing. It is a hissing noise. So it is a large subjective variation how they describe it. So that's why the imaging is a more objective finding. Once we do the imaging and we see the findings on the imaging, then we can be more certain if we can help you or not. So it is the next step is to go for the imaging, and we should take things from there. Is venous tinnitus treatable? I'm not a doctor, so sorry I missed that in the presentation. Yes, of course. The arterial tinnitus options are available in elsewhere as well, but at Cornell we have dedicated tinnitus program, which we focus a lot on the venous tinnitus pathologies. So venous tinnitus is absolutely treatable. And most of the patients that come to see me from out of state or they from outside New York are seen. These are the patients who are evaluated and not picked up by the regular scans, and they were just branded as a crazy ones, or they say it is just all in your head, forget it. Yes, it is in their head, but it is a venous narrowing, so that needs treatment. By all means, yes, venous treatment, venous tinnitus is treatable with immediate results. He showed a picture of ICA loop having a contact with the eighth nerve. Was that as an example for pulsatile tinnitus as well? Operate lots of vessel nerve conflicts. There is no explanation. Absolutely, it is. So I have a question here. It is, you have shown a picture of ICA loop having contact with eighth nerve, and they are questioning, is this the more definitive cause? No, this is one of the, I'm not an open neurosurgeon, I am an endovascular person. So, but this is been brought up as one of the causes for the tinnitus. But presence of the contact of the ICA to the seventh and eighth nerve complexes, it is not the diagnostic or the confirmatory finding, because we see this finding in many other patients who don't have symptoms at all. When you are reading the MRIs, when you are looking at the imaging, you see them, and that it does not mean all these patients have this. The ICA loop is mainly treated as a diagnosis of exclusion. You evaluate the other causes, venous pathology, and ENT issues when everything else is clear and it is impacting the tinnitus on the same side. Yes, then I see the open neurosurgery offer this as a treatment. But I am not an open neurosurgeon, but I mentioned that as one of the causes. Any more questions I can answer?
Thank you, Dr. Boddu, for your time. And please call the number on the screen if you want to make an appointment with Dr. Stieg or Dr. Boddu.
Sure. Thank you, everyone. Thanks for joining us.